You can see the screen?
Yes, sir, we can see.
Okay, right. Yeah. So today we are going to talk about the upper limb traumatic orthopedics. I have given you the tutorial before. I think you may have go through it. So we'll discuss about that in fairly quick time, and then we will uh, go through some other kind of clinical scenarios on the thing. So please, as you have the answers, probably somebody can come and answer quickly, right? So first question, fracture scapula. Anybody? A are common,
False.
false. It is, yeah, they are rare, and has a strong association with pulmonary contusion. Huh?
True.
True. Yes, that's true. Pulmonary contusion because you know the direction is right across the chest to get injured. It's also it is a high velocity trauma, so it's associated with a lot of other injuries. C. Require lateral view of glenohumeral joint. That is something from the side. Hmm?
True. True.
True. Yeah. Include fractures of acromiale. Its context is different actually. Acromiale is a lack of fusion of part of the acromion. So you might misunderstand, is mistakenly set as a fracture. So it's and usually requires internal fixation. Hmm?
False.
Yeah, false. So just going through the injuries. So they are common injuries and occurring high velocity trauma. Always when you have a fracture of sorry, of the scapula, you know that it's a dangerously high velocity, and chest X-ray is mandatory in these cases. So there can be associated injuries like pelvis or fracture femur, which are high velocity injuries. So it also associated with pulmonary contusion, and there is brachial plexus injury, subclavian and chest wall injuries. And special views are needed. And you can see this acromiale problem. It is bilateral in about 60% of those who have it. So in doubt, you can do X-rays of both sides, both scapulae. And they also usually require internal fixation. That's wrong, very rarely. Only if the glenoid cavity is involved, they need internal fixation. Right? So somebody answer this question regarding clavicle.
A true.
So it's true. Okay. Uh, uh, well, this falling on the outstretched hand, this is called Fu injury, FOOSH, right? I told you you have to remember this mnemonics also. Commonly used in clinical practice, these mnemonics and the names of certain fractures and dislocations. So, Foosh injury is called FOOSH. You understand what they stand for? And lateral one third is most commonly fractured.
False.
False.
False, yeah, middle one third. Fractures are commonly associated with brachial plexus injury.
True.
False.
False.
False, yeah. You have seen in the practice now. In the every our all our casualties, you get these people with clavicle fracture. It's very common. Sports or falls in the road from motorbikes, but brachial plexus injuries are less common. What is the kind of motorbike injury where you get brachial plexus injury? if you fall from motorbike and you in this posture, you get dragged. You get dragged along. You can get the brachial plexus lower trunk injury because C81 injury there. Fractures does not require surgery.
True.
Uh,
False.
yeah, you can't say does not. There you have to be careful with English, okay? Because how they use the word. Uh, because certain clavicle fractures need surgery, right? Need surgery in young people. They have to be repaired. Sportsmen, young people, international sportsmen, or even local sportsmen, it has to be repaired. Dislocation causes airway obstruction. What do you think?
True.
True. Yeah. If it is the medial end, if it dislocated posteriorly, it can cause airway obstruction. Right. So going through the answers, you can see it's the middle 1/3 is fractured in 80% of the time. And chest X-ray is mandatory because you can have pneumothoraxes and injuries to upper 1/3 of the chest wall. So which you have to know. So in young people, especially with this corococlavicular and acromioclavicular ligament damage, will require surgery. Regarding dislocation of the shoulder, can somebody come and answer that? Posterior dislocations are difficult to detect clinically.
True.
True.
Yeah, it's true. What type of people get posterior dislocations? How does it happen? If you fall on like that in that position, right? It can go back. The common, anybody know a common mechanism for these posterior dislocations? Uh, uh, Electrocution. You know, you do something with the electricity, and suddenly you get a jerk, and it goes that way. So electrocution is one of the injuries where you can get posterior dislocations. You must remember the other injuries which can associate with electrocution, the severe burns of the skin, full thickness, and involving the muscles, cardiac arrhythmias, and also cardiac arrhythmias, and what else? Renal failure from myoglobinuria, right? So electrocution itself is a different topic which you have to be familiar with. Radial nerve is the most commonly injured nerve.
False.
For which nerve?
Axillary nerve.
Yeah, that's right. Yeah. So, but in MCQs, now somebody might say axillary nerve is a branch of radial nerve or something, but you can't go by that. You have to look at the spirit of the question. So, what we are looking at is axillary nerve. What he says is this says is something else of the main trunk. It's wrong. Okay. So, answer is axillary nerve. Axillary nerve. It's associated with fractures, dislocation of shoulder. Anybody?
True.
Yes,
True.
you can associate with several fractures, including fracture neck or the tuberosities. So you can, there are thing called two part, 3 part, or 4 part injury. So you can have fracture to the head of the top end of the humerus that way. And any of these fractures can associate dislocations. So you have to do an X-ray before reduction. Sometimes you have a tendency to if you can't find X-ray, you take long time to do X-ray, I'll just reduce it. You must not say that, okay? Because fracture, you have to know there is a fracture or not. Because one thing is the management can be different, that people will need internal fixation. Or you can make matters worse if you try to reduce dislocation, say with the 4-part fracture. So it all internal fixation work, okay, open work. Normally on the first time dislocation, you must never reduce it without X-ray, without X-ray. And if second time, third time recurrent dislocations, you know that they happen with the slightest provocation. So you can reduce them without X-ray. This is an important practical point I want to tell you. Reduction usually require general anesthetic.
False.
False, yes. Usually we are done it under procedure. We do it under procedural sedation. And sometimes recurrent dislocations, you don't need anything really if you put it immediately. Okay. But the first time dislocation can have problems, might sometimes need general anesthetic, and also more time which has elapsed since the dislocation, you might need general anesthetic because muscles go to spasm over a time, say 5 hours, 8 hours, it can happen. Brachial artery injury is a complication.
True, but rare.
It's rare, you're right. Yeah, right. Okay. So we go to the next one. Regarding fractures of humeral shaft, A. What do you think? Proximal fragment is adducted and distal fragment is abducted. Anybody? Proximal fragment is actually abducted due to rotator cuff muscles and things like that way, and distal fragment is adducted, right? Adducted because of the teres major and not teres major, mainly pectoralis major muscle pull. Okay, so 4-part fractures mandate open reduction internal fixation. Can you hear me? Hello?
Yes, sir.
Okay. Yes. So 4-part fractures require internal fixation anyway, right? So because that's too complicated. Yes. And sometimes when you have associated fracture, if fracture segment gets into the joint area, you may not be able to reduce because that might block the fracture. Right? And radial nerve injury is common in middle 1/3 fractures.
True.
No, it's a lower
False.
1/3 actually. It's most common. Yeah.
Holstein Lewis.
Sorry. Yeah.
It's called Holstein Lewis.
Sorry, Holstein.
Is this called Holstein Lewis?
I'm not familiar with that. It says middle 1/3.
No, sir, distal 1/3.
Yeah, distal 1/3. That's right. Yeah. Usually managed with back slab.
False.
False. U slab. No, you have seen me doing it U slab. Polytrauma is an indication for internal fixation. Yes, because polytrauma patient is bedridden and we need to fix the upper limbs early so that patient can do some of his functions. So he needs the use of his hands. So you can see the answers. In the 4-part fracture, surgical neck, anatomical neck, and both tuberals are fractured. So distal 1/3 incidence about 10%, but mostly neuropraxia. So you don't need to explore. You can wait and see how things go. That's what you usually do. Right? Regarding fractures to the elbow, somebody posterior triangle shape is lost in supracondylar fracture.
True.
Yeah, you know what posterior triangle is, right? This one and that one. Lost in supracondylar fracture is actually false because it's in dislocation that you lose the relationship triangle between tip of the olecranon and two condyles, right? Two epicondyles. Okay. So that's how you differentiate dislocation clinically from fracture of supracondylar fracture. Fracture of the olecranon process is extra-articular. false. It is intra-articular. Olecranon process, although outside is extra-articular, the joint capsule get attached to the ends of the olecranon process like that. Okay. So any fracture is intra-articular. You have bleeding into the joint and all that. Walkman's contracture is a non-complication.
True.
True. What
True.
is it due to?
Immobilization.
Arterial ischemia.
Yeah, it is due to arterial ischemia. Yeah, if you take longer time for ischemia to get corrected by vascular repair or reduction or whatever, then you can get the distal contracture. Right? Fracture to the, we'll have a look at that later. Fracture to radial head is managed with excision.
True.
True, but patients will have early osteoarthritis with this and certain limitations in movements later. So in young people, tendency is to use artificial head, artificial metal head after excision. That's in young people. But old age groups, we don't do anything like that. We just leave it. Malunion is extremely common.
False.
It's true. Fractures near elbow, really malunion is notoriously common. For example, supracondylar fracture almost always end up with malunion and increase in carrying angle, increase in carrying angle. So go through the answers, please. So as you can see, it's not only olecranon process, head of radius, condyles and coronoid process, partly, part of the coronoid process, they are all intra-articular. So Walkman's contracture is a non-complication and it's due to arterial injury or ischemia. And there's myositis ossificans, which is inside the muscle, you have bleeding and then you have ossification. Basically bones forming inside the muscle. That's also another complication following elbow dislocation or fractures in that area. And also it can happen in knee, hip, anywhere, right? Myositis ossificans. Then the reflex sympathetic dystrophy or Sudex atrophy, again can happen in the arms as well as lower limbs, right? This is due to unknown mechanism. Same name, reflex sympathetic dystrophy is same as Sudex atrophy. It's due to unknown mechanism, something to do with abdominal sympathetic reaction. So regarding fractures of radius and ulna, somebody please answer. Dislocation of head of radius is common in preschool children. True. Yeah, that's what you call pulled elbow. Pulled elbow. Yes, when child is being mother hold the child's hand, and suddenly child falls, and then child will not move the arm because they have pulled elbow. So you must know the pulled elbow maneuver, how to reduce that, and then if child is okay, no need to do X-ray in this thing. Here the mechanism is very straightforward, and you know why it happened, because radial head, the ligament is more straight, has straight walls, so it easily come out. In adults, it become conoid and with more restricted. B.
False.
Yes. For this fracture, name is Montagia. Montagia. So Montagia, you can remember the mnemonic called mugger, M-U-G-R. If you can sound it like that, mugger, M-U-G-R, right? So Montagia, ulnar fracture, and Gallias is radial fracture, right? So median nerve injury can occur.
True.
True, it can. Yeah, can occur. It can be anything. No, it can occur. Right? If there's any slightest possibility, it is true. like somebody says recognized feature or recognized recognized feature of something or recognized complication. Then also, even if it happens once in 100,000, answer is true. So when you say injury can occur, again that's true. Compartment syndrome is a complication.
True.
True.
True, yes. Compartment syndrome, when you talk about it, we always think of lower leg, but it can happen in the thigh, upper arm, forearm, arm, anywhere, and abdomen. Fracture of shafts need plating in a 10-year-old.
False.
False, yes. Yes, like they have growing bones. When there's a growing bone, we try not to put metalwork as much as possible, right? So in this age, if it is severely displaced and it's difficult to keep the two reduced and keep it together, we might put a small pin or something from external pin, do the minimum metalwork. But in adults, you do plating, right? The risk of improper fixing of radius and ulna, right? If you don't fix them, various things can happen. You can have cross union, okay? Cross union, radius can unite with distal ulna and proximal ulna can unite with distal radius. So it's called cross union. Or all four can unite in one mass, right? There's a name for that in Curus or something. But the problem is with all these things, pronation and supination get seriously affected. So don't take radius and ulnar shaft fractures lightly. You have to manage properly. So you have to use it accurately in children or under 15 or 18-year-olds by using minimum metalwork but more manipulation and POP, uh, or in adults by using plating. So don't confuse this Monteggia Galeazzi thing, right? Very easy to confuse. So in radius and ulnar fractures, actually all the nerves, all three nerves can get damaged. Rest we have discussed. Fractures involving distal radius. Can somebody please answer? Dorsal Barton fracture with an intraarticular gap of 3 millimeters require internal fixation. What is a Barton fracture? Anybody? Barton's is when a distal radial fracture is intraarticular. Okay, so you must know distal radial fracture when it goes up. That is Colles fracture. Down it's Smith's, right? When there is an intraarticular element, intraarticular fracture of these things, if it is up, it's called dorsal Barton's. Down, it's called volar Barton's, right? That's a very common fracture. You must know these names, therefore, right? So 3 millimeter gap is too much. So any intraarticular fracture anywhere in the body, if the distance is about 1 millimeter, more than 1 millimeter of separation or distraction, any intraarticular fracture, like articular surface is distracted or depressed more than 1 millimeter, then it needs internal fixation. It really needs, because risk of early osteoarthritis is very high otherwise. So manipulated after a hematoma block. Anybody? Colles fractures, especially in elderly, are manipulated under hematoma block. That's a standard method because it's less risky. So what you do is you put an injection, you find the hematoma, you go with the 10 cc local anesthetic thing, and then you aspirate blood, and then you inject 10 cc into that, okay? And to 2 styloids also, because otherwise it's painful, and then you pull. minimum time for tourniquet in BS block is 15 minutes. This is a safety issue, so you must exactly know what is the time.
20.
20 minutes, yeah. EHL rupture is a complication following distal radial fractures.
True.
True. X-ray has the longest complication. And also another complication is carpal tunnel syndrome. Dinner fork deformity occur with malunion of Smith's fracture.
False.
Yeah. How do you get dinner fork deformity? Malunion of
Collis fracture.
Collis fracture. Yeah, very good. So you can see maximum allowed is 1 millimeter for intraarticular distraction. So these are very important things because you see these fractures outside. Okay. So need to refer to orthopedic surgeons. You yourself can take a decision. If the fracture is intraarticular, that's bad news. You see whether distraction is 1 millimeter this way or that way, more than 1 millimeter this way or that way, refer to orthopedic straight away. Okay. They need internal fixation. Just whatever the things would not be enough. The things, right? So Waller fractures, like now Collis fracture, you know the management you have seen. Smith's fracture, although we may reduce it at the time with some manipulation and POP Waller slab, but they almost always require buttress plate. So internal fixation is needed for them. Rest, I think we have discussed. Regarding carpus, distal fragment of scaphoid is prone to avascular necrosis in fractures.
False.
False. It's sorry, proximal fragment, yeah, because blood flow enter from the distal fragment. So proximal fragment, blood to proximal fragment come from distally through distal fragment through waist, you know, waist of scaphoid, right? Scaphoid and to proximal fragment. Scaphoid POP should be continuously applied for 6 weeks, even if initial X-ray is negative. Anybody?
True.
Not really, because it's like this, right? Very important to know the management of scaphoid. So scaphoid, you clinically, you diagnose a scaphoid fracture. You do an X-ray, it has a fracture, it shows a fracture, you apply scaphoid POP for 6 weeks. That's the first thing. Then it's okay, right? But there are many situations where you have a clinically a fracture of scaphoid, snuff tenderness, telescoping sign, and that there are clinically a scaphoid fracture on your first examination. X-ray is normal. Then you apply a scaphoid POP for 2 weeks. You remove it at 2 weeks. And then you remove it at 2 weeks and re-X-ray. If this second X-ray at 2 weeks show a scaphoid fracture, you apply scaphoid POP back again for another 4 weeks. So altogether, patient had scaphoid for 6 weeks. Then there is this third category, where you initially have a clinical scaphoid fracture. You do an X-ray which is negative. You apply for scaphoid POP for 2 weeks. You remove the scaphoid POP in 2 weeks and do a re-X-ray. Again, it's negative. Again, it's negative. But clinically, even at 2 weeks, there is tenderness and signs of scaphoid fracture. In this case, you do a bone scan. The bone scan will confirm if there is a scaphoid fracture. If bone scan is positive, then you reapply POP for another 4 weeks. But at 2 weeks, if there are no clinical evidence and no fracture on X-ray or bone scan, you just don't put any plaster, right? Just remove the plaster and that's it. Right? So there are 4 categories 4 categories when you talk about scaphoid fracture. That's a very important fracture, very common fracture. If you miss it or manage it improperly, patient can have serious consequences like a stiff wrist. Stiff wrist. It affects many employment. Medical legal issues are very high. So you must know very well about exactly how to manage scaphoid fracture. Okay. So occult fractures are detected with bone scanning. I
True.
gave the answer. It's true. D. Dislocation of lunate is common in volar direction. Now, lunate can dislocate ventrally or volar or dorsally, right? Which side is common? It's common in
Volar?
volar, yeah. Common in volar direction, and it can compress on median nerve and cause carpal tunnel syndrome. So as you can see, very many things like uh, distal radial fractures or dislocation of lunate, many things can cause carpal tunnel syndrome. Okay, they come as a late complication or probably may have signs from very early period. Widening of gap between carpal bones of more than 1 millimeter is indicative of ligament injury. It's false. It need to be more than that. So if we go through the answers, scaphoid, I think I gave you the 4 types of presentation or sequelae and how different management. Bone scanning will take about 10 days or 2 weeks until then, till the body reaction comes. You know, the bones can depend on increased blood flow in that area. So it takes few, week or two to develop. So till then, it will not be positive. If you do bone scanning immediately or 2-3 days after injury, it may not be useful. So more than 3 millimeter or more gap between carpal bones, that is you accept as a ligamental injury. That is breaking of ligaments connecting carpal bones. So now, initially when you study orthopedics, you think about basic common fractures, radius, ulnar, scaphoid, distal radius, basometatarsal. But there are many other things in the hands, right? Particularly hands, soft tissue injuries, ligaments. So that you must have extensive knowledge, tendon injuries, because they are very common. That's why you have a tutorial separately for hand injuries and infections. Okay, because accurate diagnosis and proper referrals, the management is important. So you must be aware of these less common injuries, like scapholunate dislocation. Patients often come with stiff wrist or they will complain of weak grip. Sometimes I drop things, various things they will tell you, or you have difficulty in driving or riding a motorbike, things like that. X-rays are normal, but then you must look for these ligamental injuries involving the hand and wrist area. So somebody, A. Right, this is called scaphoid. This is the cascade, finger cascade. When you relax the hand, you can see, right? Hand relaxes like that, right? So if you look at this, everything point to scaphoid except thumb, of course, right? Thumb, even thumb, you can say that. Okay, so this is the finger cascade. If this is lost, then you know that some tendon injury or something serious has happened. Okay. B. Loss of 2-point discrimination, early sign of digital nerve injury. Anybody? Can somebody answer? Hello? Hello?
False.
It's true actually. Loss of 2-point discrimination, and other thing is called pen test, anhydrosis. When you put a pen normal side, because of sweat, there is a friction, it goes slowly. But abnormal side, it goes quickly, right? Because no sweating, no friction. Okay, so those are the two tests which are useful to detect digital nerve injury at a very early stage. Adduction of thumb is an ulnar nerve function. Adduction.
True.
True. Yeah. Which adductor pollicis mainly. Allen's test evaluates circulation.
True.
True. You know what it is. Pincer grip is used to hold a key. False. Pincer grip කියන්නේ මේකනේ. මෙන්න මේක pincer grip කියන්නේ, right? Key grip කියන්නේ මේක නේද? Key grip. යතුර දාන එක. That's a different thing. So then you have power grip. Okay? Power grip. You can go through the answers for 1 minute. Okay. Anatomy of the hand. A. Ulnar artery forms superficial palm arch. Anybody?
True.
True. Yeah, it's superficial and radial forms mainly deep palm arch. If flexor digitorum profundus for all four fingers arise from common muscle belly.
False.
Yes. How does it happen? Can you explain? FDP for index is separate. Other three are common. Okay, other three are common. Common belly. But flexor digitorum superficialis is all separate, individual. Right? So when you examine the hand, this is very important for you to remember this. Okay, right? In digits, nerves are volar to arteries. Nerves are volar. Nerves are in more volar direction, arteries are there. Anybody?
False.
True. Nerves are volar to arteries. So when you have a cut, when you cut from the volar surface, nerves get damaged before arteries. Okay. Right. Ulnar artery and nerve enter hand via common canal.
False.
True. Yeah, Guyon's canal.
Canal.
Central slip of extensor tendon digitorium get attached to base of distal phalanx.
False.
False. It get attached to proximal phalanx, isn't it? Get attached to proximal phalanx, and may from either side you get the two slips going and getting together and attached to distal phalanx. Okay. When the central slip is broken, this joint comes above between two these slips, and that's boutonniere deformity for you. Be very clear cut on this orthopedics. That is one of the most straightforward surgical disciplines, right? Everything you can see and feel or describe in a diagram easily, and nothing physiological about orthopedics, isn't it? Right? Not like other parts of surgery. There's very little physiological things. So very clear cut. So once you understand something, you will not remember, you will not forget that for life. So go through your answers. So you can see this important point, the layers of the hand. Okay, layers of the hand in the tissue planes. You have the layers of the hand. Hand anatomy is very important. As a doctor, you have to know it very well, because all of you will do a little bit of hand surgery, you know, under local anesthesia or whatever. So you must know about anatomy very well, right? So you have planes, right? Different planes in the hand from here downwards. You have initially skin, right? Skin and palmar aponeurosis after that, right? And then below that you get superficial arch, the arteries. Below that you get digital nerves level, and below that you get long flexor tendons, and below that the deep arch, and below that in one plane you have metacarpals, and in between metacarpals what do you get? Introsi muscles. Okay, so these layers are very important. You must remember that very well. because when you are doing various, even suturing a small laceration in the hand, you must remember this basic anatomy. So then we said FDP for all four fingers arise from a common muscle belly, falls. And the rest we have discussed. Okay, somebody. A.
False.
False. What is the correct answer? What is the correct answer? Ulnar collateral ligament, right here, ulnar collateral ligament. So skier thumb happen when it moves in this direction, right? Rupture here. May involve bone fragment or not, but it's the ulnar collateral ligament. So it's a very unstable thumb, okay? Also might need surgical repair to correct that, because if this is unstable here, thumb is prone to move in this direction, you can't hold anything, isn't it? You can't hold anything. What is the other name for that? Other name for skier's thumb? Gamekeeper's thumb, right? Gamekeeper's thumb. There's a story about that, but I will tell you some other time, okay? About gamekeeper's thumb, why that name came for that. Bennett fracture moves first metatarsal shaft in ulnar direction. What's the answer? Bennett fracture is fracture at the base of the first metatarsal. So what happens is first metatarsal base fracture, it will fall into this side, radial side, not the ulnar side. So this is wrong, okay? Mallet's finger need immobilization for 8 weeks.
True.
What is the other name for mallet finger?
Baseball finger.
Yes, it's called cricket finger also, no? Because when you, if you try to hold a catch like that and ball hits here, then it will break, snap. So baseball finger also another name for that. Yeah. D, same thing. Baseball also you catch and it just that. D. Dorsal dislocation of proximal interphalangeal joint disrupts the volar plate. It's correct, okay, it's correct. So when we're dislocated dorsally more stress is on the volar plate, it breaks. If you get a ventral dislocation of the proximal interphalangeal joint or volar dislocation, then it will break the central slip, like, and lead to boutonniere deformity later, okay, right. So boxer's fracture with 20%, 20 degree, not percent, 20 degree flexion deformity of the fifth metacarpal neck is acceptable. You know what boxer's fracture is, isn't it? Base of the neck of the fifth metacarpal. Neck of the, you hit somebody in boxing and it breaks here. Right? Up to 35 degrees, it's okay. Up to 35 degrees, right? So you just leave it. But beyond 35, then you try to give a local anesthetic around and make finger like that and try to press. Press correct under 35 degrees, it is okay. Right? Boxer's fracture. There are other problem with boxer's fracture is not only the fracture. If you because what happens is in fights or some other situation, you punch somebody and you get this fracture, and there's a laceration there from human bite to punch somebody on the face, or foreign body or something driven in, and osteomyelitis and all kinds of things. Those are the worries. So if you must carefully look at any injuries over the metacarpal heads, so if there are injuries, you have worries. Okay, we have to look for various issues. So Bennett's, it's very unstable fracture. It needs the internal fixation anyway. So these are important to know. when you are in the faculty or clinical practice, you may not see these things, but you have to read and know this very well, because in real life you encounter these things, and you must know what you can do, what you can have to send to a surgeon, and what you have to send to an orthopedic surgeon, and what you have to send to a plastic surgeon, right? Like nerve injuries. So you have to make that distinction at your level, wherever you are working. So for make that distinction or referral, you have to be armed with the correct knowledge. With the help of clinical examination and X-rays, you must be able to recognize these things, and particularly also with the mechanism of injury. Right? Anybody? Low radial nerve injury lead to loss of sensation over radial border of forearm. No, this happens in the high radial nerve injury. Radial nerve injury somewhere up in the arm will lead to this, right? So lower radial nerve injury will lead to sensation in the hand, that problems. Anterior intraosseous nerve injury lead to loss of pinch function. It's true, okay, it's true. Watson's test check for scapholunate dislocation. Now, I think I told you last time about any joint, which include wrist joint, look, feel, move, special test above and below. Okay, that's the algorithm. That is the mnemonic. Look, feel, move, special test above and below. So you must. This is a special test. Hammer joint special test for when you are examining wrist for carpal pain, carpal instability, stiffness, right? So what you do is basically you first move it in the ulnar direction, then you press on the scaphoid and move it in the radial direction, radial deviation, and then you suddenly release the pressure. Release the pressure. Then you will feel a click. Right? When you release the pressure, you will feel a click. That is the scaphoid jutting out. Scaphoid clicking. It happens when there is scapholunate dislocation and the ligament is broken. Okay. Now, cup and saucer arrangement is lost both in lunate and perilunate dislocation. What is this cup and saucer arrangement? What is the cup and what is the saucer? Anybody? On the lateral X-ray of the wrist. Okay. So I hope you can see this. Now, this is the radius, distal radial head. Right, distal radial articular surface. So this is lunate. This is cup and this is saucer. I don't know whether you can see. This is not the right. This is the radial distal end is the saucer, and lunate is cup. Right. Then on top of that, there's a thing called apple. What is apple? Apple is capitate. Right. Apple is capitate. So cup, saucer, cup, and apple arrangement. That is a radiological normal appearance. So that is get disturbed in certain situations. Okay. So when you think about saucer and cup, now this is dislodged in arrangement is lost in lunate dislocation, but in perilunate dislocation, this is there. Right. This is there in perilunate dislocation, and only this part is gone. Apple is disturbed. Okay, apple is disturbed. There is a diagram I'll show you in a little bit. Better diagram. Passive extension causes severe pain in flexor tenosynoviitis.
True.
True. Yeah, that is one of the most dangerous conditions, flexor tenosynoviitis. In fact, about 3 days ago, there's a nurse in cooperative. She went to pick up something from the clinical material, and there was a sharp blade, a sharp scalpel blade disposed in the wrong way, and it has punctured here, middle phalanx, and then patient developed flexor tenosynoviitis, and we had to admit and operate on that patient. So it's a very serious injury, particularly common in medical and nursing, right? Getting pricks here. That's even Hamilton Bailey, I probably told you before, the famous surgeon who wrote a book, he himself had this and had finger amputated as a result of that. Because if you mismanage or poorly manage flexor tenosynovitis, what will happen is you have a stiff finger like that, which obstruct your function. So ultimately, you can't work like that, do everything like that. No? So you have to amputate somewhere here uh, to give, allow the patient. So when you're amputating finger, this is a different question. You're amputating a finger, you must leave this little bit of proximal phalanx. Why? Because when you have hold something in the hand, you hold things in the hand like that, or money or something. If you don't have at least a little bit of segment here, things might fall off, right? Coins or say even sand, something like sand, it will fall off. So to prevent that, you always leave little bit of bone here when you're amputating. Try your best to do that. Okay. So go to the answers for question number 12. So anterior introsseous supplies FDP to index and flexor longus and pronator quadratus. So Watson's test, scaphoid dislocation, and also it will test what's called DC and VC, dorsal intercalated segment instability and ventral intercalated segment instability. These names are not familiar with you, but I would like you to know that and have developed a very good knowledge of orthopedics and trauma and emergencies, which I always tell you, and that will be the hallmark of Brunei University graduates compared to rest of the Sri Lanka or rest of the world, really, right? We must try to make a difference in our stamp, our logo. So as graduates, we must try to develop more extensive knowledge in trauma, and I'll tell you, it will not go waste because you will encounter traumatic injuries, general traumatic as well as orthopedic, much more. So I'll talk to you about Terry Thomas sign or same name, David Letterman sign, same thing on X-ray, what it means later on X-ray. Okay. So remember Watson's test and also which is due to scaphoid dislocation and DC and VC, Terry Thomas sign and David Letterman sign. So we go about cup and saucer arrangement. So we discussed about that before, cup, saucer, and apple. Okay, cup, saucer, and apple. So this is a very important question which covers so many important areas. I mean, in this, I try to include a lot of things in this lecture. I mean, every bone, every ligament in the upper limb can get injured. But as I said before, about 80-20 rule, we look at in our studies to learn about 20% of all the possibilities, which comes up more than 80% of the time. Okay, they come up about 80% of the time in clinical practice or exams. So we concentrate on that. So what I mentioned here are in that 20% which comes up in 80% of the time. So that is important. In other words, they are important. So please try to read around this and okay. So regarding management of tendon injuries, can somebody please tell FDP and FDS both need repair with injuries in no man's land? You know what no man's land is? Area between distal palmar crease and distal palmar crease and proximal interphalangeal joint. Why? What is special? There is a tendon sheath, and both tendons, flex FDS and FDP, are in that tendon sheath. So it's a cramped, delicate place which needs free movement for effective hand function. So you don't mess around with that. So any injury in that area, it goes to not to a general surgeon, to a somebody who does hand surgery, either plastic or if supposing there is a wound. Now these days I am managing a patient with a wound here with ruptured extensor tendon. So wound is infected. He came late. So I am waiting for now almost more than 2 weeks till the wound heals. Once the wound heals, I will explore and repair the extensor tendon, because you can take about 1 month gap before you repair. Capenna splint is indicated for boutonniere deformity. That is true. Please go through the internet and see the splints for boutonniere deformity or what Capenna splint is. Tunneling and tendon grafts are warranted in delayed repair. Yeah, you can do that, but delayed repair for flexor tendons are very not very good. They don't have not very good results, because these things, hand is the thing which can become stiff very easily. Okay, so now from this you can go to the answers. And after that, we can go to, you must please remember this, what kind of suture you take to repair these things and the times. So make a good note for these things, right? These times are very important because they are very common things. These are very common. If you the casualty, you have seen all these injuries, right? Tendon injuries and all that. So you must know how to manage afterwards. How to manage afterwards, because as doctors often you encounter these patients either with the injury or before repair or just after repair or some time after repair with complications. So you must know the natural path. You must have the knowledge or read about the natural path and what they do, and then only you can become a good doctor in managing trauma. Right. So now we go to some clinical scenarios. Somebody please unmute and answer. Right, one person. This man has fallen on his left hand. What is the diagnosis? You can see. What is the diagnosis, you think? Anybody?
Lunate
Yes. Which
dislocation.
side? Which side? Dorsal or ventral?
Vola.
Volar. Yeah. So what is the most important complication you look for at the now? I told you what happens if it comes volar and pressure on which structure?
Median nerve injury.
Yes, carpal tunnel or median nerve injury. Yeah, you have to look for median nerve injury. Okay, so very simple. No, I mean, yeah. So you can see nicely the lunate concave surface facing the volar direction. So this is cup has been spilled. Radial surface and lunate. Okay, so more elaborate thing. You can see that cup, saucer, and apple. Capitate is the apple. You can see the on the left right lower corner. Okay, and Okay. Right. So these are very important things. We have a clear picture, and when you see the X-ray, you should be able to recognize these things. So, when you look at the look at the wrist X-ray, don't look at it blindly hereafter. You look in a systematic way and search for common injuries. Now you know something about those injuries. Okay.
Terry Thomas sign.
Yes, that's right. That is Terry Thomas sign, right? This is a British comedian. Terry Thomas is not a surgeon. He's a British comedian. Some surgeons are comedians also, right? So you can see he has a gap between his teeth. And here you can see the gap. That's why it's called Terry Thomas sign. It's also called David Letterman sign. I don't know the reason why. You can see a fairly noticeable gap, isn't it, between the scaphoid and lunate. So that's disruption of the ligament. So what are the abnormalities you see on this X-ray? Anybody?
Fat sign.
Yeah, olecranon, no. Be very careful of these things, right? Young people have unfused epiphysis, so you must recognize epiphysis from fracture. That's a very common pitfall. What are anybody?
Fat pad sign is there, and these capitate.
Can you see a break here?
Supracondylar.
Sorry? Yeah, it's supracondylar. Supracondylar fracture is there. And also you
And
can
fat
see
pad sign is also there.
it's a fat pad sign, yes. Not anterior and posterior, no? This anterior fat pad, this posterior fat pad sign, and the supracondylar fracture, yes. Right? So what are the complications you result from any supracondylar fracture? Right? Let's go through these complications. What is this? Red, swollen, tender, warm, stiff, distal, wrist. What do you call it? Following supracondylar fracture.
Non-ischemic contraction.
No. This is called Sudeck's atrophy or reflex sympathetic dystrophy. Okay, reflex sympathetic dystrophy or Sudeck's atrophy. Red, swollen, warm, very painful hand after this injury. Okay, after some maybe few weeks after supracondylar fracture. Even after reduction, you can get that. You may reduce it, and it's normal after that fracture, but patient can develop. So this is due to immobility or some sympathetic nerve abnormality, which exact mechanism has not been found yet. So aggressive physiotherapy is the answer. Daily aggressive physiotherapy. Okay, in addition to anti-inflammatory painkillers. So what's this on the right side? Something else. What's that?
Walkman.
Yeah, that's Walkman's ischemic contracture. That's how it looks like. So Walkman's ischemic contracture, right? So you can see it's more, the hand is more ventral, right? Flexed, because when contracture affects volar muscles are more powerful, right? Powerful, and they tend to flex more. That's why it bends in that direction. Flexors are more affected. What is this on the left side of your screen? This is also following supracondylar fracture.
Myositis
2 months.
ossificans.
Yes, very good. Myositis ossificans, because there's hematoma in the muscle which become calcified or bone formation, right? In fact, it's bone formation occurs. So you can prevent this by giving non-steroids early, right? Non-steroids early. But when it happens, you can't do anything other than gentle physiotherapy. Sometimes it's large calcified things you may remove surgically, okay? But must avoid that by gentle physiotherapy from the early days, and of course reducing the hematoma to surrounding area of a fracture. This can occur anywhere in the body following direct trauma. Sometimes without a fracture also, when there's muscle damage and muscle hematoma without a fracture. still you can develop myositis ossificans. So this is one of the things you must be able to recognize and how to manage. And now you have supracondylar fracture, you reduce it, well, but patient develop this 1.5 years time or 2 years time. What has happened? Anybody?
Benediction sign.
It's not Benedict, it's a claw. It's ulnar claw. Sorry. This happens because I told you there is will be always malunion with increasing in carrying angle, and as a result, ulnar nerve gets stretched. You get ulnar neuritis and ulnar palsy, which comes later slowly. So that's called tardy ulnar nerve palsy. TARDY. Tardy ulnar nerve palsy. That is tardy can be delayed hearing. Late, right? Delayed ulnar nerve palsy. But if you detect the problem early, you can do what's called ulnar transposition, because ulnar nerve is normally posterior to medial epicondyle, but you can put it anterior to the epicondyle by surgery called ulnar transposition. Then tension is not there and you can avoid these things, right? Otherwise, patient will develop this ulnar nerve palsy. So a supracondylar fracture is a dangerous injury next to dislocation of knee and I mean every fracture and dislocation is associated with problems. So you must know these things. And supracondylar fracture is common and affects young people, so they have lifetime to develop these complications. So you must be quite familiar with this complications and their detection, diagnosis, and management. Okay. Anybody? What is this?
Bone scan after.
Positive bone scan.
Yeah, this is a positive bone scan. I told you, I think before we discussed nicely about how to manage scaphoid fracture. So in two weeks, you remove patient has clinical scaphoid fracture, and then you do X-ray, it's normal. Then you want to confirm, you do bone scan, then this is positive. Okay. What is this? Hmm?
Intramedullary needle.
What is the bone which has been fixed?
Humerus.
Yes, yes, humerus has been fixed. Yeah, one is intramedullary nailing. What is the other one?
Nail and plates.
Nail and plate.
Nail and plate. Yeah, plate and screws. Yeah, it's called plate and screws. And what is the disadvantage with intramedullary nailing? Anybody? It can rotate, okay? The bones can rotate. No, it's not hold, it will, unless interlocking nails are there, the bone segments can rotate. So you can have rotational malunion, and it can be a problem later, okay? And plate, the problem is plate is weak, really. It is a bit weak. So it can break, and if your patient try to do some more work, it's not strong, very strong. So after it heals, it's okay, but during the time up to healing, complete healing, it is weak. So actually, many people use both. They put an intramedullary nail and also put a plate that's called derotating plate, a small plate to prevent it from being rotated. Okay, so these are basic orthopedic management principles. So you must know about these things, because as you know, orthopedics is one of the most heaviest subjects in the surgical spectrum. Okay, so two different methods of fixation, and in fact you can use both. That's better in the case of humerus. Now what is the diagnosis? What are the injuries you see? Anybody?
Gallus. Gallias.
Gallias, that's right, Gallias. So you have dislocation of the ulnar head and fracture of the distal radius, right? MUGR, LERC, radial fracture, Monteggia ulnar fracture, right? And the dislocation of that. What is this? What are the two injuries you see on X-ray?
Barton.
Yes. Is it a dorsal Barton or volar Barton?
Dorsal Barton.
See where the thumb is on the right hand corner. See where the thumb is in which direction?
Volleyball.
Volar Barton. So yeah. So you have basically you have Smith's fracture and intraarticular fracture both. Okay. So what is the optimum management here? Close reduction, open reduction. I told you dorsal fractures, simple collies, you can do close reduction. But everything else, if there's intraarticular element or even isolated Smith's fracture, very often you need internal fixation with buttress plate. Okay, internal fixation with buttress plate. So these things need internal fixation normally, unless in very old or frail people, it need internal fixation. Okay. Now, what is your diagnosis?
Flexure tenosynovitis.
Yes, involving the right middle finger, sausage shaped finger. You can see the point, and that's the tendon sheath is underneath, flexor tendon sheath. And how do you manage this patient? Right, elevation, IV antibiotics, surgery. You make a incision here in this area, and one incision this area. You do that, and then irrigate with normal saline for a day. You can put a cannula for the top end of the thing, cannula here, and with the normal saline drip, you can irrigate for 24 or 48 hours and let the fluid come out from the bottom end of the incision here and to a big gauze pack like that. You wash it basically over a long time, give you antibiotics, and then you manage it. So most feared complication is the stiff finger, right? Stiff finger. Right? I told you there are 3 indications for amputation: dead, deadly, useless. So stiff finger is a useless finger. Stiff finger is a useless finger. Okay, so you will have to amputate. So this patient has punched a wall, and here is finding difficult to move his thumb afterwards. What is the diagnosis? Can you see any abnormality? Huh? Sorry? Can you see any abnormality in the thumb? Because the thumb he has a problem with. Can you see something?
Bennett.
Bennett, that's right.
Bennett.
Very good. Yeah, Bennett fracture. You can see that it's dropping to the side, it's unstable. So this will need internal fixation. Okay, Bennett fracture. So when you look at the hand next time, so this man also has punched somebody. What are his problems?
Boxer.
Yeah, boxer's fracture. Of course, the angulation is not too much. It is about 20 degree or 30 degree, something like 30 degree angulation. Neither. Is acceptable. But the problem is the other things. What happened? Yeah, problems. Yeah, that's right. So this injury is a very dangerous injury. You have punch on the face, most likely teeth. So you can have several problems. One is loose tooth fragments can be there. Then there can be underlying fracture, as you mentioned before. And this tooth can cut the extensor tendons, extensor expansion and things, and damage that. It can also involve the joint, septic arthritis, or osteomyelitis, right? So osteomyelitis, septic arthritis, foreign body, and rupture of extensor system, and severe cellulitis. Severe cellulitis, because you know that oral bites, human, dog, or whoever, they have multibacterial and lead to nasty cellulitis. So he has several problems in his hand. So these are emergencies. So IV antibiotic, broad spectrum, SOBs, X-ray taken to theater, tetanus toxoid taken to theater, and proper irrigation, washing, exploration, all are needed, followed by gentle management, right? You have to prevent those problems from happening, right? X-ray, you must look for foreign body like fragment of tooth or fragment of glass if the patient has punched the glass or wall. In that case, it will be a stone. So I think we covered fairly big area about theory and clinical practice, as you do not have time to go to clinical practice. So whenever I give a lecture next time, also we are talking about orthopedics next week, lower limb, orthopedic trauma affecting lower limb. There also I will do it like this: first questions and discussions of theory, and then followed by some clinical scenarios, because you are at home mostly. I think these are important. So this punching thing, where the Bennett fracture occurs, when during the punch, if thumb is straight, there's axial loading, right? Loading straight onto the thumb, you will get this Bennett fracture. So this boxers is something else you punch on the face of somebody. So same punch, but slightly different angles with that. Okay. So I think we have covered the whole thing in fairly thorough way. Any questions? Okay, right. So we'll meet next week also.
Excuse me, sir.
Yeah.
So is there a recommended textbook or some reference for us to check this? Because Bailey and Love doesn't give a
No, it is
very good account.
Apply's orthopedics. Apply has two books, right? Big book and small book. You know, for medical students, what they recommend is Apply's orthopedic small book. I think it's in our list of recommended books in surgery department list. You can get it from the library. I told you who Graham Applis last week. So father of orthopedic surgery, right? Yeah. So that's the book. But not only that, now about sometimes you can go to internet. In addition to that, you can go to internet and read about them. And orthopedics is very physical, right? Very physical. So you can go through the injuries and various names. When you put it at image or something on the internet search, you can find. So when you see something clearly, you know, like we can see the Bennett's thing here, you remember it for rest of your life when you see an image or picture, no? So that's the best way to, looking at the pictures is the best way to learn orthopedics. Okay.
Okay, so thank you.
Right. Then.
Thank you, sir.
Yeah, you're welcome.
Thank you.
Thank you, sir.
Thank you,
You're
sir.
welcome. Right.
Thank you.
Thank you.
Welcome.